Okay, next topic is glaucoma. It's a group disorders characterized by optic neuropathy due, in the majority of patients, to raised intraocular pressure. It's now recognized that a minority of patients with raised IOP do not have glaucoma and vice versa. So may have or may not have IOP, raised IOP. In acute closure glaucoma, there are two types of acute closure and closed closure. There's a rise in IOP secondary to an impairment of the aqueous outflow. So acute angle aqueous outflow. Aqueous outflow. Remember that. Acute angle aqueous outflow, ACAC. Second to an impairment of the aqueous outflow. Factors predisposing to the AACG include hypermetropia, long-sightedness, pupillary dilatation, lens growth associated with age. So mydriatic drops are known precipitant of acute angle closure glaucoma. Acute angle closure glaucoma. Mydriatic drops, drugs which may precipitate acute glaucoma, including anticholinergics and TCA. So mydriatic drugs, as in the one which opens up the pupil. So as in pupillary dilatation also can cause that. Features are severe pain, maybe ocular or headache, decreased visual acuity, symptoms worse with mydriasis, watching TV in a dark room, hard red eyes, visual severe pain with this for glaucoma, hard red eye, halos around lights, semi-dilated non-reacting pupil, corneal edema results in dull or hazy cornea, systemic upset may be seen such as nausea and vomiting, and even abdominal pain. Treatment of acute glaucoma can be acetazolamide or pilocarpine, which will cause miosis. So hypermetropia or pupillary dilatation or lens growth or mydriatic drop can cause that. It will decrease the aqueous outflow, so thus causing increase in IOP. And what is the management for that? Management is urgent referral to the ophthalmologist. Management options including reducing aqueous secretion with acetazolamide. So acetazolamide will cause decrease in secretion, and pupillary constriction with topical pilocarpine. Topical pilocarpine will constrict the pupil. So acute angle closure glaucoma is associated with hypermetropia, and hypermetropia as in like long-sightedness, and primary open angle glaucoma is associated with myopia. Okay. So next is primary open angle glaucoma. POAG is referred to as chronic simple glaucoma, and it's present in 22% of more than 40% years old. And what about the other one? Previous one was it's not mentioned how much common is it. Other risk factors include family history. So age is the major risk factor. Family history, black patients, myopia, hypertension, diabetes mellitus. So this can be more common, I think, because since it's related to two very common diseases, hypertension, diabetes, primary open angle glaucoma. So this one may present insidiously, and for this reason it's often detected during routine optometry appointments. Features may include peripheral visual loss, nasal scotoma progressing to a tunnel vision. So POAG can cause tunnel vision as well. Previously we studied more about tunnel vision, retinitis pigmentosa. This one and also cause tunnel vision and decreased visual acuity, optic disc cupping. Okay. So in optic disc cupping, basically the optic disc becomes larger. That's called cupping. The majority of patients with primary open angle glaucoma are managed with eye drops. These aim to lower intraocular pressure, which in turn has been shown to prevent progressive loss of visual field. So this one will also have increased intraocular pressure. So the medications that can be given is all these five. Prostaglandin analog like latanoprost. Latanoprost will increase uveicular outflow. So once daily administration. Adverse effect include brown pigmentation of the iris. So this is the adverse effect. So the flow will be increased, thus the pressure will be decreased. Beta blocker timolol that will decrease aqueous secretion, should be avoided in asthmatics and patients with heart block. So If you remember the first one, it was acute closure angle glaucoma, which one was maintained by acetazolamide for decreasing aqueous secretion and pilocarpine for causing miosis. And this one is the other one. Even latanoprost, beta blocker, sympathomimetics like brimonidine and alpha 2 AD receptor agonist also decrease outflow and production of aqueous humor, decrease aquatic aqueous production and increase outflow. So avoid if taking MOI or TCA. Adverse effect include hyperemia. Okay, carbonic anhydrase inhibitors, dorzozolamide decreases aqueous production, and myotics pilocarpine increases vesicle flow. So this one is also used here. Acetazolamide is also used. But myotics, as in pilocarpine, increases UV cycle flow. Adverse effect include constipated people, headache, and blood vision. Okay. Surgery in the form of trabeculectomy may be considered in refractory cases. Surgery can also be considered. Optic neuritis causes can be multiple sclerosis, diabetes, syphilis, and features can be unilateral decrease in visual acuity over hours or days, poor discrimination of colors, red desaturation, pain worse on eye movement, relative afferent pupillary defect, central scotoma. Okay, prognosis MRI if more than 3 white matter lesions, a 5-year risk of developing multiple sclerosis. So this is unilateral decrease in visual acuity over hours or days. This can be due to optic neuritis. Hours or days. Retrobulbar neuritis, inflammation behind the optic nerve head, and the optic is normal. Patient sees nothing, doctor sees nothing. So basically, no one knows what's happening. Visual acuity loss frequently. Optic nerve looks normal on fundoscopy, so this is the big clue here. Afferent pupillary defect during the swing flashing light, color vision will be reduced. Red looks paler. Also, red desaturation happens here. Optic neuritis. Okay. Differentiating between papillary edema, retrobulbar neuritis, and papillitis. So papillary edema is basically what is it? Swelling of head of optic nerve secondary to increased intracranial pressure. Site can be bilateral, should be bilateral. Visual impairment, increased blind spot. Fundus, hyperemic, hemorrhage central, no peripheral. Vessels appearance engorged or tortuous. Pupillary light reflex not affected. Treatment decrease ICP. So this is for papillary edema and raised intracranial hypertension, or anywhere like that. Retrobulbar neuritis, of course, it's inflammation of orbital portion of optic nerve, and you can see it. Site is unilateral, and central scotoma to complete blindness. Fundus normal, hemorrhage normal, vessel appearance normal, pupillary light reflex decreased, corticosteroid with caution. And papillitis will be inflammation of the infraction of the head of the optic nerve. So the orbital portion is the head of optic nerve. Site will be unilateral, central scotoma to complete blindness, hyperemic fundus, hemorrhage on optic nerve head, engorged veins, and treat cause or corticosteroids. Okay. Next topic is problems related to systemic disease, for like ophthalmological problems. Ocular manifestation of rheumatoid arthritis are common. With 25% of patients having eye problems, of course. Ocular manifestations of rheumatoid arthritis. So, keratoconjunctivitis sicca, most common, KC. Scleritis, erythema, and pain. So, Spain, if you remember Spain. Scleritis, erythema, and pain. Episcleritis only erythema. Corneal ulceration can be there. Keratitis is with actinic rosacea as well. Swellitis is painful, episcleritis is not painful. So, iatrogenic, steroid-induced cataracts, chloroquine retinopathy. Thyroid eye disease affects about 25 to 50% of people with Graves' disease. It's thought to be due to an autoimmune response against an autoantigen, possibly the TSH receptor causing retroorbital inflammation. The patient may be euthyroid or hypothyroid or hyperthyroid at the time of presentation. Smoking is the most important modifiable risk factor Radioiodine treatment may increase the inflammatory symptoms in thyroid eye disease. In a recent study of patients with Graves' disease, around 15% developed or had worsening of eye disease. Prednisone may help decrease the risk. So the features will be exophthalmos like this, conjunctival edema, papillary edema, ophthalmoplegia. Inability to close eyelids may lead to sore dry eyes if severe and untreated, can be at risk of exposure keratopathy. Topical lubricants may be needed to help prevent corneal inflammation caused by exposure. Steroids, radiotherapy, surgery can also be needed later. Indications of urgent referral to the ophthalmologist for this can be unexplained deterioration in vision, color vision, suddenly popped out eye, deterioration in vision, color vision, suddenly popped out eye, lobe subluxation, corneal opacity, visible cornea when the lids are closed, disc swelling. Okay, so herpes zoster ophthalmicus describes the reactivation of the varicella zoster virus in the areas supplied by the ophthalmic division of the trigeminal nerve. It accounts for around 10% of the cases of shingles. Features can be vesicular rash around the eye, which may or may not involve the actual eye itself. Hutchinson sign, rash on the tip or side of the nose, indicates nasociliary involvement and is the strongest factor for ocular involvement. Management can be oral antiviral treatment for 7 to 10 days, ideally started within 72 hours. Topical antiviral treatment is given in HZO. Oral corticosteroid may reduce the duration of pain but do not reduce the incidence of post-herpetic neuralgia. Ocular involvement requires urgent ophthalmology review. Okay, complications can be ocular, conjunctivitis, keratitis, episcleritis, anteuveitis, ptosis, and post-herpetic neuralgia. So what you have to remember is the features mainly and the treatment as well. Vesicular rash on the eye, Hutchinson sign, rash on the tip of the side of the nose indicates nasociliary involvement, and oral antiviral treatment for 7 to 10 days. Or corticosteroid can also reduce the duration of pain and all that. Okay, diabetic retinopathy, of course, the very common cause of blindness in adults around 35 to 65 years old. Hyperglycemia is thought to cause increased retinal blood flow and abnormal metabolism in the retinal vessel walls. This precipitates damage to endothelial cells and pericytes. Endothelial dysfunction leads to increased vascular permeability, which causes the characteristic exudates seen on fundoscopy. So pericyte dysfunction predisposes to the formation of microaneurysms. Neovascularization is thought to be caused by the production of growth hormone factors in response to retinal ischemia. So there will be macular edema, prevalence 26% of background retinopathy, 26% pre-proliferative retinopathy, and this proliferative case. Risk factor is more the increased HbA1c, proteinuria, duration of DM. Okay, so in postgraduate exam, you are most likely to be asked about the characteristic features of the various stages and types of diabetic retinopathy. Recently, a new classification system has been proposed, dividing patients into those with non-proliferative diabetic retinopathy and those with proliferative. Okay, this is retinopathy with dots and blots and hints of laser surgery for TM retinopathy. So proliferative and non-proliferative, two main groups. So this is the traditional classification. This is like background retinopathy. There is microaneurysm dots, blot hemorrhage 3, hard exudates, and pre-proliferative retinopathy is cotton wool spot, soft exudate, ischemic nerve fibroid, more than 3 blot hemorrhage, venous bleeding, looping, deep dark cluster hemorrhage, more common in type 1, treated with laser photocoagulation. And for new classification, mild NPDR, that is non-proliferative diabetic retinopathy, is one or more microaneurysm. Moderate will be microaneurysms, blot hemorrhage, hard exudate, cotton wool spot, venous bleeding and looping and intraretinal microvascular abnormalities. Severe can be blot hemorrhage and microaneurysm in all four quadrants, and venous bleeding in at least 2 quadrants, IRMA in at least 1 quadrant. IRMA is this intraretinal microvascular abnormalities. And proliferative retinopathy, urgent referral to an ophthalmologist for panretinal photocoagulation. Retinal neovascularization may lead to vitreous hemorrhage, Fibrous tissue forming anterior to the retinal disc, more common in type 1 diabetes, 80% blind in 5 years. Microaneurysm on fluorescent angiography is the earliest sign of DM nephropathy. Maculopathy based on location rather than severity. Anything is potentially dangerous, serious. A hard exudate and other background changes on macula. Check visual acuity, more common in type 2 diabetes. Asymmetric DM retinopathy, suspect ocular ischemia. Carotid artery disease. Screening can be type 1 diabetes, newly diagnosed DM after 5 years, from 5 to 10 years annual, more than 10 years 6 monthly, and type 2 annually. Trochlear nerve palsy causes torsional diplopia. Torsion is a normal response to tilting the head sideways. The eyes automatically rotate in an equal and opposite direction so that the orientation of the environment remains unchanged. Vertical things remain vertical. That's the end of ophthalmology.